The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell from Leading Age Michigan, and we want to welcome you again to another Safe and Calm webinar for Friday, October 23rd. Today, we're going to basically follow up on yesterday's discussion about visitation, and we do have a few short updates as well. We did review all of the information as of yesterday and kind of tried to consolidate it and streamline it and put it into some categories. So we'll go through that a little bit later in the call. First, as usual, we're going to start with some brief advocacy updates from Dalton.
Good morning, everyone. This morning, we're going to run over a couple of things really briefly. A couple of bills that are moving throughout the process, bills that have been signed, and just some finer nuances to some of those bills. Not a ton of detail, but just the points that are relevant to us. Firstly, I labeled the slide bill tracking. These are just bills that are moving through the process and things that I think you guys should be aware of and we all should be aware of. As we talked about on our last Wednesday call, there's a medication aid bill out there. Last time we discussed it was going to be in committee. It did clear committee, but just so you know, that bill is still in the process and moving forward. There's also another bill that was just passed by both chambers. So this is heading to the governor for signature. That is going to essentially make a bunch of the department's information about COVID in nursing homes public. We'll cover that in more detail on next Wednesday's call, but just know that that bill is in the process of becoming a law still. Moving forward, we do have some good news to report. There were a couple of bills signed over the weekend, and this is a picture from that bill signing. The governor signed a bunch of bills from her home. Firstly, the Senate Bill 1094, which is the one that contained the CRC rules, the dedicated unit rules. That bill did get signed, I think it was 2 days ago. And then also the healthcare liability bill for the first wave of the pandemic. That bill was also signed, that we've been following through the process. And once again, the effective dates for that civil liability for healthcare providers are March 29th through July 13th. There was also a larger liability package signed. We haven't talked about this much. It's been briefly mentioned. It contains four House bills, technically, but really one of those is just defining what COVID is. So really it's 3 bills. These bills set the minimums for civil action and provides generalized liability protections for businesses throughout the state. And so who do these basic protections apply to? They apply to persons who have complied with federal and state statutes, persons who own or control premises that or designated or used to provide healthcare services or to provide shelter to patients or for quarantine for people in response to the COVID-19 pandemic. And those relate to the death or injury of an individual or the loss of property damage, as long as you are still following federal and state procedure and there was no negligence or willful or criminal misconduct. There's also general protections for employers regarding an employee's exposure to COVID-19, as long as that employer was operating within federal and state statutes. And once again, there are exceptions to all these things for negligence or willful or criminal misconduct regarding the COVID pandemic. Interestingly enough, a person is not defined as you would think. It does include other entities so person in this case means an individual, a partnership, a corporation, an association, government entity, other legal entities, including schools, colleges, and nonprofit charitable organizations. These protections all apply starting January 1, 2020, so they apply retroactively, and they go from that point forward. So these are just kind of some base level protections for businesses in Michigan. There's also some return to work criteria established in there. I know we have our own, but this is the return to work criteria for businesses in general. So if an employee tests positive for COVID or displays symptoms of COVID, they shall not return to work unless the following conditions are met. Should the employee have a fever, they have to have 24 hours since the fever has stopped without the use of fever-reducing medications. And then they also need to have had 10 days of having passed since the symptoms first appeared or they received a positive COVID-19 test. Moving to another topic, there's another round of provider relief funds that is coming out. The department issued an L letter a couple days ago. An additional $20 billion was added to the program, and applications are due November 6th, so it's coming up. So if you think you can apply for these funds, I do encourage you to do so. We have heard from the department that for various things, people are not applying. So please look into it and see if you can apply. The eligibility criteria are here. I'll do a brief review of those, but if you need more detail, they're right here. So the eligibility criteria are providers who were previously eligible for the Provider Relief Fund but did not apply, providers who have previously received fund dollars that approximate about 2% of their annual revenue from patient care. They may submit more information to become eligible for additional funds. Behavioral health providers who have billed an insurance company, and lastly, healthcare providers who began practicing January 1st, 2020 through March 31st, 2020. And these include Medicare providers, Medicaid providers, assisted living facilities, and behavioral health providers. And I included a link on this slide. That link will actually take you to the homepage for this program. That includes multiple FAQs, it includes eligibility criteria, it includes the actual application, and that's also where to submit the application. So if you are interested in applying for these funds, please click that link or use that link. Lastly, I wanted to bring back the important dates slide, a little bit updated this time. One thing I do want to point out is the deadline for the Nursing Facility Infection Prevention and Control Enhancement Grants. Those grants, the state has not received enough applications to drain all the funds, and these are the funds that will go away December 31st, and so it's kind of a, if you don't use it, you lose it scenario. So if you do have a project that fits those CMP funds, or those funds, they're not CMP funds. If you do have a project that fits those, please apply for these. These are things not like PPE, these are things like structural improvements. So the example that you've heard me say multiple times if you've attended these calls are it counts for the hand sanitizer dispenser, but not the hand sanitizer. So if you're looking to make a purchase for one of those, please apply for monies through that program. I also added a couple of deadlines here. The November 6th deadline for the Provider Relief Fund applications are on here. And then I also added the November 15th deadline for MD, HHS, and LARA to post a public plan regarding the care and recovery centers and distinct units from that bill that was signed earlier this week. And then the rest of the deadlines are much the same, but these are some important dates, so please be aware.
All right. Thank you very much, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. So I do have a couple questions. Must a positive resident be transferred to a CRC post November 15th?
So I haven't seen the plan. I don't think there is a plan out there yet that's been posted by the department, but the bill does state that if a positive resident or if a resident tests positive and you are not a CRC and you have not applied to the state to have a dedicated unit, that they must be transferred somewhere that has somewhere to care for them, whether that be a CRC or a dedicated unit.
Okay. And then you can submit for the grants if you have already purchased the items. For example, we have already purchased visiting booth material. Can we submit a grant for these items?
The visiting booth grant is different than the nursing facility infection prevention grant, or I forget the exact name, but there's two different grants here. There's actually one for visitation items, and there's another one for kind of structural improvements, air filters. But yes, you can apply retroactively, I believe.
All right. Thank you very much. It looks like that was the last question, so we can go ahead and move forward.
Thank you, Dalton and Blake. We're going to go through a very few short list of updates, and then we'll get into visitation. So this was what I got last night from the department to remind everyone about the infection control grants that Dalton was just talking about. So this is the text that they asked us to put in here. The applications are due in October because, again, you have to spend the monies by 12/31. So we don't need to go through that anymore, but the text that they want you to know is here. You can read it on your own. HFA AFC reporting. So yesterday evening, the department put out a new rule that says that all Michigan AFC and HFA facilities with a bed capacity of 13 or more will be required to transition to a new platform for COVID reporting. So these are just licensed facilities now. They have not talked about unlicensed facilities as they did in the past. The other platform, Survey Gizmo, that has been decommissioned. Transition to the new platform will occur in two stages. First, you have to register, and you must register on October 28th between 7 a.m. and 12 noon. That seems to be the only option. At that point, each facility will receive an individualized link for their future reporting. And the first weekly reporting then is to be completed on Wednesday, November 4th by noon. Afterward, it's due on every Wednesday thereafter. So even though we've talked about the fact that these entities haven't had to report, they do need to start reporting again. And we are hearing rumors from the department that possible HFA and AFC testing is coming down the road as well. So they're holding two webinars for this purpose. The information is here. I believe that I did send this link out on the listserv this morning so that you can register for the sessions, which are next week. SNF reporting, I think you probably all know this by now if you were trying to report yesterday. But when the department, I think it's 2 days ago, changed the daily SNF reporting requirements to weekly effective next Wednesday, they locked out the system as of Wednesday, and members had been having difficulty. They clarified that essentially the change is effective now, and no further reporting is due until 10/28. So you only have to report from this point on weekly, and that's something that we argued for quite loudly. We knew that the department was not using this information on a daily basis, so this is a good thing. Okay, more grant reporting changes. So for the provider relief grants, we just got some notices late yesterday that some of the definitions are changing, and it looks like it's going to be in a good way. So apparently they're changing the limits on the amount of lost revenue that a facility can provide. So we're going to ask Plant Moran. We have asked them. We haven't got a confirmation yet to join us. Hopefully next week. We'll see when they're available to explain these ongoing issues because they keep changing the grant reporting requirements.
All right, thank you. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. As of right now, we don't have any questions, so we can keep on keeping on.
Okay, so more on visitation. Firstly, and this is what I really want to talk about first because there's been so much confusion and I have received and sent so many emails about this issue. This is the official risk level for every county. Now it is still dated October 21st, and we don't have information from the department how we're going to access an updated version of this in the future. But this is where you must get your level from. So if you look at Oakland County, which is, these are in alphabetical order, so it's here somewhere, it's a D. Now that's pretty high level risk. It's not an E, but it is a D. So if you look at this, that is the official county level. Moving on to the next slide. Now a lot of persons have gotten confused because, and this is what I believe is happening, is that when you pull up your county using the MySafe Start map, you do have the ability to pull up your county, put that in the drop-down box, and your county will show in the bottom of the screen, just like I have here. And then people will say, well, it's different. Yes, it is different, but that's not your county level. That is the region level that your county is in. So you'll see that it says risk level C. If you click on any of those counties in that area, they will all say C. In each region, they're all the same because these are not county level risks. These are regional risks. So the MySafe Start map will never tell you the county level risk unless they change the system here. There's no way to do that. That is why they sent you the list. And when you, again, look, if you're not looking at that county level on the left, but you are looking at your Oakland County, you have identified that as the area, you can get your test results and your new cases. But again, that's not your overall risk level. Those are different risk levels just for those subcategories. So again, there's no way to tell your county risk, at this point at least, from the MySafe Start map. Okay, so we're going to go back and we're going to talk about the residential care visitation order again. And we're going to review these grids because I think the grid is a little difficult to understand sometimes and a little confusing. You can move on to the next slide, please, Blake. So basically, safety precautions and parameters apply to all the visitation types. We're not going to go through those again today. And outdoor visits are allowed as long as there's no facility outbreaks for 14 days, no matter what region you're in. You're not allowed to even have outdoor visits if you have a facility outbreak. For low A and B risk areas, indoor visits are allowed. Pretty much irrespective of testing and any other qualifications other than the basic safety precaution rules. For C and D, indoor visits are allowed with testing. End-of-life visits never require any testing according to the guidance. In risk areas E, although indoor visits are not generally allowed, visits for compassionate care are allowed with testing. ADL visits are allowed. End-of-life visits, again, never require testing. One of the things that the new guidance does do is it differentiates between the types of compassionate care. We've never seen that before. So in our view, we were always pretty much addressing end-of-life care, critical care, hospice care, etc., all as in one group. But this differentiates them, and our feeling is that they're going to have to differentiate between end-of-life and hospice a bit for us to really effectively apply these rules. So this is the second piece. I'm going to go through this kind of column by column in the next couple slides. So we're going to talk about when visits are allowed regardless of county risk level, when social distancing is required, and when testing is required. So again, if you don't have access to this, I don't believe we've sent it out yet. We will send these guidelines out that the department created, but remember that they are linked right off of the press release. So the first column is which visits are not restricted by the guidance at all. In other words, in terms of a facility outbreak or in terms of your risk level. So this is very complicated. Section 2B says that that window visits, ADL visits, end-of-life visits, visits when critically ill or hospice, and medical providers are free to happen regardless of whether or not you have outbreaks or not, or no matter what area of risk your facility is in. Then they eliminated non-medical service providers, resident physicians, and volunteers. So those people are now subject to restrictions. They can't be utilized in E, and they cannot be utilized during facility outbreaks. Now the confusing part is that Section 2E tells you that all of this list on the left are not subject, except for testing, to visitation restrictions, and that's not really true, and that's why it's so complicated to figure this out. However, it is consistent with what is written in that guide that we just looked at a minute ago. It's just hard to figure out from the narrative. So one of the big changes is that non-medical service providers, resident physicians, and volunteers are not allowed to be coming in your facilities. And we're going to talk about this a little bit more later in terms of our questions and issues, if you're in E and if you're having a facility outbreak. Social distancing, some other problematic areas here. Currently not restricted for ADL support, that's what it says in one part, but it doesn't in the grid tell you that it's limited to 15 minutes, but it is in the narrative. End of life care, obviously limited to 15 minutes of contact. Medical service providers and non-medical service providers who have to approach the resident in order to serve them. Obviously, there are flexibilities in the social distancing requirement. However, there must be 6 feet distance for window visits, critical conditions, and hospice residents. And again, we need a definition of end of life. Social distancing is required for resident physicians or clinical students. Well, then what is the point of having a clinical experience in your facility if you can't get more than 6 feet toward a patient or a resident, and not for volunteers. And volunteers at some points are transporting these people. So I don't know how you can transport them and be 6 feet away. So these are issues that we're all going to talk about when we list our issues and questions. When to test. Testing is never needed for visitors during window visits, outdoor visits, or end of life. Testing with staff protocols. Medical service providers, your non-medical service providers, resident physicians, and clinical students and volunteers need to be tested, but they are tested during the same protocol that you use with your other staff. One of the questions that we got yesterday, I think misinterpreted the phrase resident physicians. To me, resident physician meant someone who was interning or was a resident who was working with other physicians on site. In other words, they were in training to some degree, or they might be medical students. But we have included that in our questions to make sure that they define what they mean by resident physician. Visitor testing for indoor visits in C, D, and E. Testing is required for all indoor visits for C and D, except at end of life. In areas E, you have to have testing for ADL, critical conditions, and hospice visits, and everything except end of life. And again, we're going to ask for that definition. So it's taken, to be honest with you, quite a work to go through all of the different wording back and forth from the guide to try and figure this out. So I consider it quite complicated. We're trying to kind of drill down to the essential pieces, which those last 3 slides hopefully will do. And now to the questions and issues that we have to date, and I've tried to organize them. So the first set of questions was about reimbursement. So it's our understanding that the state plans to provide point of care test kits. And this all came from the call, however. There's nothing in writing about this. And if needed, point of care machines to nursing homes. We want to verify that that's correct. And we pretty much sure that everybody has to have a CLIA waiver. And I would strongly suggest that every licensed entity, AFC, HFA, and nursing home get a CLIA waiver if you do not have one now. Will MDHHS reimburse for specimen collection time? I believe that they said they would. Again, we don't have anything in writing. Will MDHHS reimburse for the PCR testing of visitors? That's very much up in the air. We're not sure what they're going to do. And if visitors use their own lab or arrange on their own, are they going to be responsible for the cost, or is this something that the department will reimburse for? So I want to pause right now, go back, and I want to ask, is there anything else about reimbursement that you all care about that you want us to communicate to the state? This list is going to go this afternoon to them. So we'll give it a minute or so. Blake, I'm assuming you're not getting anything else if you're not speaking?
Things just started to pop in. I was not getting anything for a little bit. Somebody said when they add HFA, we will have more questions for them, I am sure. We are a CCRC. Do we need to have CLIA waivers for both HFA and SNF? Oh, that just passed.
My understanding is that you need a waiver for every TIN number that you have, but we can research that individually. Leading Age National is really an expert on the CLIA waiver issue. Are there any other, Blake?
Not that I'm seeing.
Okay, so let's move on to the next section. And if you think about something for reimbursement, you can put it in there at any time. But I was trying to kind of coordinate the issues into groups. So for physical structures and layout, hugging stations, like can they be used like windows or outdoor visits? In other words, if you're using a barrier, and you may have seen the pictures where a person puts their hands through this large glove things. If there's really no contact, can they be considered like window or outdoor visits if they're outside? And would those be allowable? They're not really, that kind of scenario isn't ever addressed. Someone asked yesterday if they're in risk level E, They want to know if they can create a visiting room with their own entrance that has a fully sealed glass or plexiglass wall to prohibit any chance of transmission. They want to know if they could consider that a window visit because it's kind of indoors, but it has a barrier to it. Technically, it is indoors, though, that has its own entrance, but it's not necessarily in the facility itself, the facility proper. What makes a sheltered structure acceptable for outdoor visits? We, again, have been referred many times to the local fire department, but they can't tell us what the requirements are, if any, to differentiate between a separate building, which could be construed as an indoor visit, simply not in the facility. So if you had, let's say, a chapel, I think that would be good. Could you have your on your campus, but completely separate? Could you have people meet in the chapel and call that an outdoor visit, simply because it's not in the facility? And if so, would there be requirements other than social distancing and masking? Many facilities have several different levels of care. We talked about this yesterday. And utilize common areas. Unless the settings are separated completely in different buildings with no crossover of staff, how should these organizations consider the scenario where they might have a positive resident independent living, but not a nursing home or assisted living? So that issue is out there. And someone asked for a definition of a well-ventilated area. They just keep saying that all these visits should occur in well-ventilated areas without really defining that. Okay, so any other questions about physical structuring? Did you get any other questions at all, Blake?
Well, I have a lot of questions, but not necessarily for that specifically now.
Okay. Let's go through them now so that they don't build up too much.
Okay. I did just get one. They said besides fire marshal, who can inform?
I was only told the fire marshal, and that's what we want clarification about. We really think that they should define an outdoor visit structure. They want it sheltered, but they don't define it, so we're going to ask for that.
Okay. And you would just want to start going through the questions now then?
Yeah, go ahead.
All right, give me 1 second. Where do we get the level from?
Okay, so that level is, at this point, to my knowledge, only through one link that is on the press release. We can send the press release out to everyone again this afternoon, and it is simply a PDF link. There is no, and it's only for that one date. So we figure that they're going to have to update that and figure out a way to distribute it. But that is one of the questions going forward, is how are we going to access that on an ongoing basis?
County risk, where did you find your county by county list? How can we find that?
Same question. Off the press release. We will send the press release out again.
Oh, yeah, we got to have a couple of those. Where do we get the grid that shows the testing needs with visits?
The testing needs with visits is also a link off of the press release, and we'll send the entire press release out that has all of the handouts and attachments that you need, or that we've gotten so far. Let's say that.
Since IL is no longer part of the visitation rules, if there is a COVID case in IL, does it impact visitation in AL and IL?
That's what that's one of the questions that we just put forward. We don't know how this will be considered. We want to ask them how they're thinking about situations where there's a shared care settings on one campus.
So if we cannot use the SAFE map as a resource for visits, what should we use to determine?
It's that list. It is that column list that I showed you that links off of the press release.
Isn't a resident physician a medical provider?
That's what I would think too, but I think a resident physician here is meant to be a medical student or an intern or a resident working in an area under a physician. That's what I always assumed that they meant by that. However, it was obvious in some questions that came through yesterday that other people were considering this the resident's physician. I don't think that's a medical service provider. So I'm asking them to define that, but I believe it is a student physician.
So does this mean beauticians are not allowed?
Beauticians are allowed in certain areas, but they're not allowed always, and we have to go back to the grid to determine what exactly that is. But beauticians and other non-medical service providers, they have limited them in a different way than they did before.
So I understand correctly, volunteers are allowed as long as you aren't an E-risk level or during an outbreak and they just get tested weekly with the rest of staff.
That's correct.
If we are an E county, are outdoor visits permitted?
Yes, as long as you don't have an outbreak.
So salon service, already answered that. Is a tent with sides considered an indoor visit?
My understanding is that that's an outdoor visit, but that's what we're seeking clarity on.
Does resident physicians mean students? Can we have students in the community when in level E?
Go back to the grid. I think it'd probably be easier to have that in front of us. At least it'll be easier for me. Okay, stop. So now repeat the question because my brain can't hold information for more than a minute.
Does resident physicians mean students? Can we have students in the community when in level E?
No.
Okay.
Well, let's go back. I don't have the guidance in front of me. One of the issues that I have here is that they grouped in county risk level and facility outbreak in one and the other. But I do believe that, go back a couple more, go forward a couple slides. Go back up one. Okay. Which visits are not restricted by the guidance? They are limited by county risk level and facility outbreaks. So you can't have non-medical service providers, resident physicians, or volunteers in E and not during any facility outbreak. That's the painful part. So yes, they are restricted.
Do these visits have to be supervised by a staff member?
That's one of the questions that we have later. It does imply that the volunteers are still monitoring visits, but there is no direct statement in there about that after I re-looked at it last night. So we've included that on our question list.
What defines end of life? Is it actively dying or on hospice and death is expected within a couple weeks to a couple months?
Again, we're asking for a definition for that.
Yesterday, you stressed that visitor testing was only for SNF. You did not mention that today, so I just want to confirm that HFA, AFC, and assisted living are not required to test visitors prior to indoor visits.
That's true as of today. However, we do know that there's some work going on that may require it in the future.
What is our responsibility if visitor is positive?
That's another question that we're asking the state. We don't think that you have any responsibilities other than protecting your residents from that person, but that's on our list as well. So let's stop here, although you already have the questions. A lot of these questions are questions that we already have, that we don't have clarity on, and we already have on our list. So let's finish our list, and then we'll do the rest of the questions. Next slide. Okay, so one of the issues is use of the point of care test, and some facilities are reluctant to use those, and it does seem like the department is focusing all of its efforts here on use of those point of care tests. It would be an organizational nightmare to go ahead and try and get this testing done if you're using PCR tests that often have a long turnaround time. So our question to the state is, are they expected really to provide point of care tests for all these visitors? Some facilities aren't comfortable with conducting them. It seems like all of the testing provisions are built on that expectation. And then what are you going to do if you don't want to do point of care tests? I don't know that you can, going forward, continue to limit visitations simply on that basis. So I think there'll be some problems there. Can a nursing home require that visiting testing be completed on their own if you are uncomfortable? Although that would be hard as well in different ways. Can you do that if you want to? How will we get physician orders? That's going to be burdensome, and there is additional staff that's going to be needed to conduct visitor testing, and that's going to be burdensome as well. The current guidance is unclear about whether each visit must be individually monitored. It says volunteers can provide this monitoring role, and the individual who's trained in infection control is not required to monitor. But again, as I said earlier, there's no clear statement that says each visit must be in view of a monitor at all times. Another question that we have is about contractors. Contractors kind of fall under non-medical service providers, but technically those service providers are only allowed in your building if indeed there's some great resident need. Well, if you want to take a wall out for some other reason, is that a great resident need? In other words, this is kind of a gap area. We did know in the past that contractors, construction workers, etc., were allowed in the building if they were working in a distinct part away from the residents for non-essential issues, and they were only allowed in the residential area for emergent or essential necessary services at the time. Well, this new guidance is like silent on that, and so we're asking that question here as well. Physical distancing. The guidance provides that for ADL visits, medical service providers and non-medical service providers, that they can be within 6 feet while providing services, as long as it's less than 15 minutes. In general, this is not enough time for feeding, hair care, and potentially other service or medical service needs. So, and the grid identifies this time limitation only for end of life, but not for these other scenarios, but it is in the narrative. So we want them to think about that a little bit. We assume that although clergy might be restricted during outbreaks and based on risk level, they are in that non-medical service provider list, but that they would not be restricted for an end-of-life visit. And again, here's the definition for resident physician. We assume that for indoor visitation, if the visitor is not within 6 feet of the resident, that a cloth face covering is sufficient. If doing ADL care or in contact during end-of-life visits, we assume that they would have full transmission-based precautions. In other words, you would have to be gown, gloved, masked. But would you need a face shield? Would you need an N95 if you were a visitor? That's not clear. The 15 minutes in contact requirement for physical distancing, is that 15 minutes per episode? Can you, is that per visit? Is that per day? Is that per hour? There's no real clarification about that. Accessing the county risk level list. They're going to have to tell us how we're going to access those updated lists because there's only one right now. And what will be the protocol for changes in visitation based on fluctuating county risk levels? In other words, if one day you're an A and the next day you're an E, what's the protocol for that? Are you going to have to go into like a whole, how are you going to inform all of your residents that and their families that quickly that your visitation has changed. How are you going to do that? If you are going from a higher risk level to a better risk level, how will that happen? So we want to make sure that we understand that there's some implementation time here. These risk levels are going to go up and down. There's some facilities that are concerned about opening up visitation this greatly when the state cases are surging in some areas. So what to do if the facility is concerned about that? Are these visitation rules mandated? That's not clear. It's going to take a lot of time and energy to get this visitor testing done. Is there a way that you can train non-licensed persons to conduct the testing? Does the testing requirement, which is generally weekly now, for medical and non-medical providers still apply if the rule is that they have to have resident contact for less than 8 hours per week? The new guidance is silent on that piece. Do visitors have to be tested inside or outside? How will they test them outside of the facility? And probably not should be tested inside. What is their expectation for that? What are the facility's responsibilities if we find a COVID positive visitor? That came up just a few minutes ago. And again, if there is a positive in a separate independent living area, do we need to report it to the other care level residents, family, and staff? We talked about this again. 15 minutes is usually not long enough to provide enough service, and that needs to change. Another thing is resident physicians and clinical students often provide direct care. Why would they be required to physically distance? It would often negate the very reason that they're doing their clinicals. Again, volunteers may be transporting. So these are things that we are questioning as well. And it appears that these persons are not allowed to visit in risk area E or when there's a facility outbreak. This is new and it's kind of burdensome because these people are almost like staff. They have the same infection control training. They have the same requirements for PPE. Why would we treat them differently than your regular staff if they were coming in and doing their clinicals? Since independent living settings are now excluded, there are still a lot of business rules out there that apply to employers and other environments. So what are they for independent living? Since pretty much independent living residential kinds of settings are not necessarily included in a lot of the other revised orders. So what orders or rules would affect them in terms of what they need to do since they're not covered under visitation guidance anymore? And here is, please, define end of life. Okay, so I'm assuming that you probably have a list of questions there, Blake, yet. Let's go through them one by one. If they're on the list already, we'll just skip over them. And I can help you identify that if necessary.
Yeah, thank you. I was going to say. So this one is pretty long, so just letting you know. The FDA requires in the literature for emergency use that all positive results must be confirmed using PCR method, and the sensitivity and specificity is very poor, leaving room for a high incidence of false negative results. The other caveat for the FDA requirements is these instruments and AG tests must only be performed on symptomatic patients, which is not what you want to use these tests for. There is not an option to ignore the FDA requirements for any testing. I struggle with the rest of the world not following the FDA requirements as written when performing these tests on asymptomatic patients.
Okay. I will try to respond that individually because this answer is rather long, but I actually believe that the FDA has put out in their Q&A an updated guidance about the use of point of care testing for serial testing for asymptomatic persons and staff, especially in nursing homes. I know that the CDC guidance has done the same and CMS has done the same. So I really do believe that the idea is that, considering all of the real options in the world here, a point of care test is that you do on an ongoing basis is much better than a PCR test that you have to wait 5 days to get the results for. And that there is the CDC protocol on determining how to follow up those testing, depending on whether or not you're in a high or a low transmission area. And there's an algorithm, a chart, that does that. So this is, I don't think, as controversial anymore as it was in the beginning. And I do think that there's FDA guidance that speaks to the use of these antigen tests for serial testing of asymptomatic people. And I will forward that to you when I find it individually. I can send it to everybody if they want it.
SNF EMR reporting, if we realize we need to correct a value from our Wednesday reporting, how do we do that considering it is locked down outside of reporting times?
To be honest with you, I'm not familiar with corrections to EM resource. I'm assuming is what you're talking about, reporting. But I will look into it. We do have a good relationship, a great relationship really, with the testing and reporting people.
How are air exchanges per hour measured?
I have no idea. Is that one of the criteria that you have to report? What is that from?
I'm
don't.
Not sure.
Okay, so if whoever asked that question, if you could give me a little bit more information, that'd be helpful.
What kind of PPE must be worn by visitors when visiting? Is the facility expected to provide this PPE and also for indoor visits?
My understanding is, and we've asked a clarifying question for this, is that masks should be the only thing that's required as long as there's no contact and you're keeping 6 feet away. Additional PPE would be required for ADL visits if you're getting close to the person, etc. Again, we have another question about the level of that. If the whole facility is using N95s, would you expect the visitor to use an N95 as well? My understanding is that in a previous guidance, the facility was expected to provide anything beyond the mask, and I would think that they would provide a face covering too if needed. But if you required extra PPE in order to deal with a resident, the idea was that you would have to provide that.
How often is the county list updated?
I'm not sure. I thought it was going to be updated daily, but again, we don't have enough information about how to access it and how they're going to do that yet.
Someone says county list. There's a link in the order that takes you to a website rather than a PDF, although it is unclear how to navigate there on your own.
Okay, I'll have to look at that. I'm not sure how to respond to that right now. I do know how to get to that list, so we can talk about that later, I guess.
Did you say volunteers are allowed in general with testing?
Volunteers are allowed for specific visitation-related activities, which are scheduling, screening, monitoring, and disinfecting. Those are the only stated reasons why you can have a volunteer. But yes, you can't have volunteers based on with routine testing like your staff, and as long as you're not having an outbreak, because you're not going to have any visitation if you're having an outbreak.
Should we be requesting COVID test results of surveyors as well?
Well, we would like to, but you're not going to be able to at this point. Leading Age National has been working with CMS for quite a while to try to get them to mandate surveyor testing, because it makes no sense to be testing everybody else except the surveyors. However, right now there's no requirement for that. It's up to every individual state, and the state is not requiring it. However, I could add that to the list.
What info is recommended for us to collect for POC testing? Also, are we required to notify the local health department of a positive?
Okay, I would have to know whether or not you're a nursing home or you're not a nursing home. I would assume that a nursing home would know what they have to collect at this point. There is a guidance out from Dr. Caldoun that listed what you needed to report to a local health department. And for nursing homes, positive and negatives have to be reported through EM Resource. There's some question about what they're going to do with the new NHSN pathway yet for point of care testing. So it's a complicated issue. There is guidance for nursing homes. There is guidance for non-nursing homes too, but they're not required to do it. So there's not a whole lot of
She just said,
rules out there.
I was just going to
Go
say, she
ahead.
said the POC question is for visitors, what info to collect, and if we have to report visitor positives.
I believe that you do have to report, but that's a good question. Let me put that on the list.
Okay. Indoor visits, do they have to be supervised by a staff member?
That's a question that's going to the state.
What is the latest recommendation when there's a suspected COVID resident? Isolate in place or move to COVID unit? Can you rule out respiratory illness first before moving them to a COVID unit?
Read that again, please, Blake.
What is the latest recommendation when there's a suspected COVID resident? Isolate in place or move to a COVID unit? Can you rule out respiratory illness first before moving them to a COVID unit?
You must always rule out everything before you move someone to a COVID unit. You must have a positive COVID test to move someone to a COVID unit. That's absolutely required. If you suspect COVID, you can isolate them in place. I would suggest testing with a point of care test immediately and seeing what you find. If the person still has symptoms, continue to isolate until you know for sure what is going on. If someone has symptoms, you should always treat them as if they are infectious and potentially positive, even if you get a negative report.
Is email an acceptable means of written notification if a visit request is denied?
I don't think that's 100% clear, but I would think that you could do that as if it were me, I would definitely ensure that I had some acknowledgement that they received it. The guidance is actually silent on that. I'm not sure what they would think about that. I'm sure all of that notification requirement came from the Ombudsman office, so I can certainly talk to them.
That link to the county category list. I'm just trying to read it to see if it's a repeat. I'm just going to read it anyways. That link to the county category list, will that be provided every day, every week, or how often? Also, is that the list you shared a snapshot in time that matches the Michigan State start map county numbers?
Okay. That list will never, until they change the My Safe Start map, will never match. Okay, that list, although I changed it because it's one long column on the link. I don't know how often they're going to update it. I think it's daily, and I don't know how to access it yet. They're going to have to tell us. That's one of the big questions of the day, really. I think I've answered all of that. I'm not sure there was a lot of parts to that.
Okay. There was two people that basically just put in near the same time. I just checked the link in the Michigan Safe Start map, and the info is now updated for yesterday's date. This must be the correct link. And someone else just said, click on the list right now. The date is updated to October 22.
Okay, all right.
Where does the order or other document indicate that the visitor testing requirements apply only to nursing homes at this point in time?
In the narrative, it says that for entities that are required to test, testing provisions are. So there is a preface to the paragraph that has the testing requirements. So it doesn't just say nursing homes, though, which was kind of a warning that what that means is that if HFAs and AFCs start to have to test, they're going to have to do these things for visitors as well. But it does say in the narrative, and that was confirmed in a discussion with the department on Wednesday afternoon.
The current recommendation is to report all point-of-care test results to MDHHS, negative or positive. Is this accurate? We test over 160 employees every week, and running the tests and reporting all of the results will be very time-intensive.
Yes, I understand that. We think that the entire thing is going to be quite burdensome to add all of these visitors to your already reporting requirements, and we'll let them know that. However, what we anticipate is that they're going to say, well, that's the only way you can have visitation, though.
Is there a template from MDHHS for denying visits?
No, not at this point, at least.
All right. As of right now, it does look like that was the last question. So if you do think of anything later after this webinar has concluded, feel free to shoot an email over to Dalton, Deanna, or the Safe and Calm at leadingagemi.org, and we will make sure to get those questions answered for you. We would also like to thank Deanna and Dalton, and we would also like to thank, we are up near 100 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I hope everyone has a great rest of their Friday and enjoys their weekend. As always, our next Safe and Calm call will be scheduled for Wednesday, next Wednesday at 10 a.m. Eastern Standard Time, and you should receive your email notification like always. Deanna or Dalton, do you have anything else you would like to add?
I do want to add that if indeed you have something that you think is a critical question that you want to go to the state, you're going to have to forward to us in the next hour or so, because we will be getting our question list to the state this afternoon. Thank you, everyone, for your patience. I know that this is very complicated. I've gone through it 3 or 4 times now, and I still struggle with some pieces. So we appreciate your endurance, really, through this whole pandemic. Thank you very much. Have a great weekend. Try to get some rest.